Hi friends, today we are going to discuss about aortic stenosis. This specific video contains a handwritten notes which is very much useful for MD general medicine final year exams as well as for NEET PGs and as well as NEET SS level exam, because this is directly driven from Harrison latest edition. So let's get into this. Aortic stenosis. Aortic stenosis is the most common valve lesion among the adult patients. Adult patients, I mean, is most common of the chronic valvular heart disease. The aortic stenosis is the most common. Approximately almost 30% of patients who are aged about 65 years of age have some or the other degree of aortic valve sclerosis, thereby which later leads to stenosis. The presence of non-obstructive aortic valve sclerosis in patients above 65 years of age are at excessive risk of myocardial infarction. It means even if aortic valve is not being stenosed, or there is no clear obstruction, or there is no clear remodeling of left ventricle due to aortic stenosis or any of the heart failure symptoms, you can still have a myocardial infarction. That risk is very high in non-obstructive aortic valve sclerosis patients. This is the brief introduction about aortic valve stenosis. Now let's get into the etiopathogenesis of aortic stenosis. Aortic stenosis in adults is basically a degenerative calcification of aortic cusps. Basically, aortic valve contains three cusps. It's a tricuspid. It have three leaflets. So this degenerative calcification of aortic cusps usually happens on the substrate of three different kind of underlying diseases. It can happen even without any underlying disease over age, but most common uh, thing it happens is over the substrate of congenital heart disease. The most common congenital heart disease which can lead to aortic stenosis is bicuspid aortic valve, and the second one is chronic trileaflet deterioration. This is which is most common among the adult patients, old age patients above 65 years of age, and the previous any rheumatic inflammation, any kind of rheumatic heart disease in the previous age, during their younger age or before the older age. Whenever he is getting it, he must be having some or the other kind of rheumatic heart disease. Then we have to be careful about aortic stenosis development in the future. Now let's talk about the traditional risk factors associated with development of aortic stenosis over time. When you're not having any specific congenital heart disease or any previous rheumatic heart disease, you must not also have these traditional risk factors to avoid getting a aortic stenosis in your patient. The most common of these traditional risk factors are hypertension, diabetes, dyslipidemia. Among this, dyslipidemia, you have to be very specific about increased LDL cholesterol, total serum cholesterol, and lipoprotein A, which have direct risk factor of developing aortic stenosis over time. Also, we have to take note of smoking, CKD, that is chronic kidney disease, also, and metabolic syndrome also can be the risk factor of developing aortic stenosis. Among these risk factors, hypertension, diabetes, and dyslipidemia are even more important, because among the patients of aortic stenosis, about one third of patients, the attributable risk is just among these three risk factors, that is hypertension, diabetes, and dyslipidemia, which are more important and which can cause aortic stenosis if they are uncontrolled or not taken care of. And this is the direct image from a recent edition of Harrison, where it gives a clear idea of about how aortic stenosis is developed over time. This is a bit complex and I'll make it easy for you. The initial thing that happens is the endothelial injury. How an endothelial injury happens? It can happen by over old age, or by the underlying hypertension or underlying dyslipidemia, or the most important thing that we have to discuss here is mediastinal radiation exposure. You can see patients where they have mediastinal radiation exposure when they're going through the treatment of like lymphomas, especially Hodgkin's, where there are mediastinal masses for which the patient will go through radiotherapy where they can have mediastinal radiation exposure. These are the various examples of how endothelial injury happens. And after this injury happens, what happens? The lipid gets accumulated through this injury. The lipid accumulation especially contains the LDL cholesterol and lipoprotein A. When these are accumulated, they undergo oxidation in that area. And this oxidized LDL or oxidized phospholipid later causes the inflammatory response. This is the most important step. This inflammatory response causes cytokine release in that area, in that valvular area. And what happens to the valve? The valve will be having interstitial cells. They are called VICs, valve interstitial cell. This gets activated and they get osteogenic transformation. How do they transform? They transform like osteoblasts by the mediation of BMP, WNT signaling and TGF beta. These mediators makes this VICs, that valve interstitial cells, to undergo fibrosis. Fibrosis by collagen deposition as well as leaflet thickening. And this leaflet thickening later over time undergoes calcification. This calcification is by the specific compound, that is calcium hydroxyapatite deposition. This calcification further causes valve stiffness, reduced mobility, thereby aortic stenosis. This is a simple simplifying of this image, and you can go through this image if you want to, and or else you can just go with this simplified flowchart. And next comes rheumatic heart disease cause as a cause of aortic stenosis. How rheumatic heart disease cause a aortic stenosis? Especially it can cause aortic stenosis by commissural fusion. And these among these three leaflets, two leaflets can undergo commissural fusion and makes it look like a bicuspid wall. And these bicuspid walls, when they are very stiff, they are more susceptible to trauma. And of course, when you know that trauma, there is injury and there is scarring, there is fibrosis and there is calcification. So the most important thing we have to understand here is rheumatic heart disease producing this commissural fusion can mimic a BAV, bicuspid aortic valve, which is a congenital heart disease which can itself cause a aortic stenosis. So you have to be very careful when you are diagnosing a patient of BAV or a rheumatic underlying heart disease, which our surgeon have to decide on what's the treatment depending upon the type of underlying heart disease. Also, when there is a rheumatic heart disease, the mitral valve is most commonly involved. So you might also see the rheumatic heart disease associated aortic stenosis can also have mitral valve involvement. So sometimes you can also have aortic regurgitation along with aortic stenosis, and these are all complicated. We'll discuss in the next slides. So as we already saw, mediastinal irradiation in like treatment of Hodgkin's, there can be scarring, fibrosis, calcification and stenosis. Just to cover it, bicuspid aortic valve briefly, because it is very important as a underlying cause of aortic stenosis. Bicuspid aortic valve BAV is a most common congenital heart defect. We all know it. So the congenital heart disease, its inheritance is most commonly autosomal dominant, and some few it is mentioned in Harrison that it can be also a X-linked recessive, because it is the most common kind of heart disease, heart defect in Turner syndrome, which is a X-linked disease. And next comes the pathogenesis of BAV, where there is medial degeneration plus ascending aorta aneurysm. The medial degeneration is nothing but when there is bicuspid aortic valve, the left ventricle should apply a lot of pressure to pump blood out of this aortic wall, because it is a little stiff. When there is a lot of blood being pumped out, there can be a medial degeneration, media of the aorta. This medial degeneration later gets transformed as ascending aorta aneurysms also, because media gets thinned out, which can later cause an aneurysmal formation, which is very common in BAV. Very less frequently there can be a coarctation of aorta also due to this medial degeneration. So when a patient with BAV versus patient who is having tricuspid aortic wall stenosis, the aorta size on even a chest X-ray or your echocardiogram can also give clue about if it is a BAV or not, because aorta size is pretty larger when it is compared to a tricuspid wall stenosis. Then comes the Siever's classification of BAV. Siever's classification is not that important for us right here. It usually has three types: type 0, type 1 and type 2, where RAFs are being divided. And the most common of these three types are type 1, where it is associated with aortopathy. And you need not know much more than this right now. Let's go forward with pathophysiology. Let's discuss it with diagrammatic explanation in between. So, how it starts? Pathophysiology of aortic stenosis. What is an aortic stenosis basically? Aortic stenosis, this is a normal heart. When a normal heart, there is blood being coming out of left atrium into the left ventricle, and this left ventricle have to pump blood into aorta through the aortic wall. So when it is normal, there is no issue. But when it is aortic stenosis, that is the orifice of aortic wall is decreased, and this aortic wall stenosis will occlude the amount of blood being pumped out of left ventricle into the aorta. So this is being occluded in a aortic stenosis. So what happens? This is nothing but a left ventricular outflow obstruction, LVOO. That is the initial step of atrial stenosis. This creates the pressure overload on LV. So when the left ventricle is supposed to pump blood into the aorta, so it have to have enough pressure, increased pressure have to be applied over this aortic wall, because it is stenosed. The orifice is very small, so the amount of blood that have to go through have to be increased. So that will cause the increased amount of muscle, because it's a kind of you can call it as compensation. It's a compensatory mechanism. When you lift weights, your biceps increases. Just like that, when you apply more pressure to go out of for making the blood to go into the aorta, your heart muscle also increases in size. This is called hypertrophy. Why is it hypertrophied? Due to the increased amount of pressure that is required for the blood to enter into the aorta. So this is called nothing but a pressure overload on LV. So this leads to a LV aorta systolic gradient. Gradient is nothing but the pressure between two areas. This is the wall, and there is a pressure here and there is a pressure here. The amount of pressure in between these two is most important, because it have to pump blood into the aorta. And when the gradient is increased, when there is a stenosis, obviously the pressure between these two areas is increased. That is nothing but increased LV aorta systolic gradient. How do you measure it? You can measure it on echocardiogram. In the latter part of the video, you can understand what is being seen in echo. So in echo, you can see the mean gradient is greater than 40 mmHg, which is referred as severe AS, or the jet velocity greater than 4 meters per second, that is also severe AS. These are the echocardiographic findings. You need not stress much, just know about the values. Next comes this compensatory phase. Compensatory phase, just I have explained what is a compensation. Your left ventricle have to compensate for the amount of obstruction here. This obstruction is making the left ventricle to grow in size, and this is nothing but the hypertrophy. According to the Laplace law, the stress is directly proportional to pressure and radius, but is inversely proportional to thickness. So to decrease the amount of stress, you have to increase the thickness. There is no other way. So the thickness is increased for the coping up of the stenosis. Now the concentric hypertrophy. Why is it called concentric hypertrophy? Because when there is pressure overload, the sarcomeres, they are increased in parallel. So this increases the thickness of the myocardium of LV, that is left ventricle. It increases concentric hypertrophy. This is a significant pathognomonic, I can't say pathognomonic, but it is very specific to aortic stenosis. So through this mechanism, cardiac output is maintained because you have enough more muscle. Now it gives more pressure to maintain the cardiac output when it is required. So patient remains asymptomatic. You don't even know that the patient is having aortic stenosis until you do some kind of routine investigation have revealed that there is aortic stenosis in such patient. They are most commonly asymptomatic for decades. Next, coming the valve area reduction. The usual valve area of aortic valve is 3 to 4 centimeter square per meter square. But for the severe aortic stenosis to appear, your valve area have to come down to less than 1 centimeter square. Only then the symptoms appear. What symptoms will come to it? And after this, as the valve area is decreasing and decreasing and decreasing, the compensatory phase now goes into the long latent phase, where the LV becomes thick and stiff. Why it becomes thick and stiff? Because your LV, your left ventricle is increasing in size. Not the cavity, but the wall. This thickened muscle is making the left ventricle very stiff and non-compliant. It's not non-compliant, it is decreased compliance. This decreased compliance will make left ventricle more stiff and less contractile. So when there is decreased contractility, the amount of blood being pumped out of left ventricle into the aorta is also decreased, obviously. So this have to be noted in the long latent phase. Next comes the diastolic dysfunction. The diastolic dysfunction is stiff LV. Stiff LV, how does it cause a diastolic dysfunction? Diastole is nothing but relaxation. You have a LV which is very big, having very big wall, and which is also very stiff, and you are not having enough wall, you're not having enough cavity to relax. So the amount of cavity is decreased. The normal left ventricle is like this, but your concentric hypertrophy made your left ventricle very small. So that cause decreased or impaired filling of this left ventricle. This further causes increased LA pressure, and that, so when LA, let's draw a diagram clearly for you to explain, for you to understand. This is a heart. See, your left ventricle is already very much in hypertrophy due to the concentric LVH. Now what happens? The amount of blood coming down is decreased. So when the amount of blood coming down is decreased, the amount of blood remaining in left atrium is increased. So where is the blood coming into left atrium? Through pulmonary veins. So when pulmonary veins are pumping blood and there is no enough space in left ventricle, the blood can pull up in pulmonary veins. So where are these pulmonary veins? They are in lungs. So when the blood is being pulled up in pulmonary circulation, there is increased pulmonary congestion. So there is increased pulmonary hypertension. So how you will get dyspnea? Through this back pressures. When these back pressures are increased, the pulmonary circulation is being pulled up with the blood that is not being pumped into left ventricle. So this causes dyspnea, especially exertional dyspnea in initial stages of aortic stenosis when it started being symptomatic. Next is myocardial ischemia. I can't say infarction in such patients. These patients might not even have coronary artery disease, but the patient might develop myocardial ischemia. How? Because simple, the concentric LVH is itself says that there is increased mass. This increased mass is having the same amount of blood supply, but there is mass which needs more of blood supply, but there is no enough blood supply. So what happens? The epicardial arteries which supply the blood from outside, epicardial arteries, they are coronaries, they supply from the epicardium, they pass through epicardium, myocardium, but they can't reach the area called endocardium, subendocardium. So the patient will develop ischemia, especially in the subendocardial region, and this can be seen on ECG as ST segment depression in almost most of the leads, like even in chest leads as well as in limb leads, suggesting that the patient might be having an STEMI kind of picture. This is very dangerous because this patient is in increased O2 demand which is not being reached. So this causes angina in our patient. So next stage is maladaptation. What is maladaptation? There is enough hypertrophy for the initial few decades, but over time this maladaptation happens because the hypertrophy which is ongoing is not a healthy one. It is a pathological hypertrophy. So which can happen. What happens with the pathological hypertrophy? The patient might also develop myocardial fibrosis. This fibrosis can cause decreased compliance and then decreased contractility. So all the compensation you are having since few decades, it undergoes into decompensation. What happens in decompensation? The hypertrophy is not coping up with enough pumping pressure. There is no enough pumping pressure. What is being uh, going into dysfunction? It is systolic dysfunction happens due to decompensation. So there is no enough pumping pressure. When there is no enough pumping pressure, there is decreased stroke volume. When there is decreased stroke volume, there is decreased ejection fraction. When there is decreased ejection fraction, you'll have all the symptoms of heart failure. When there is heart failure, it can back pressure into your pulmonary walls, and this pulmonary veins. These pulmonary veins will go back. The pressure goes into pulmonary arteries. From pulmonary arteries, the pressure goes into the right side of the heart. This right side of the heart also starts failing. This is a cycle of where the patient initially will have the left ventricular dysfunction and finally the biventricular dysfunction happens, which is total heart failure. Now let's come into the symptoms part. What are the symptoms? The clinical features, as we already discussed, severe AS only will have the clinical features. Until then, the compensatory phase keeps on going for decades together, like 2-3 decades. You might not even know what's happening with your heart. So symptoms appear after your heart walls, aortic wall goes less than 1 centimeter square of area, and you'll have the features of exertional dyspnea, angina pectoris, and syncope. We all already discussed about dyspnea and angina, how they are being uh, set in our patients of aortic stenosis. Now we didn't discuss about syncope. How the syncope, it's also a similar mechanism. It is because of decreased arterial pressure. Your blood pressure drops because your heart is pumping less amount of blood. Either it can be due to advanced stage of decreased stroke volume, or initially sometimes your ejection fraction might be normal because you'll have decreased cavity of left ventricle, but ejection fraction is normal. So your amount of blood being pumped out as stroke volume is decreased. So with that amount of fixed cardiac output, your exercising muscles, or when you are in exerting, or you are doing some amount of work which is not usually done by you, there is the muscles require more amount of blood, which leads to vasodilation, and this vasodilation will not be compensated by the vasoconstriction of other muscles which are not in action. So all this together can cause decreased BP, and that can cause decreased syncope. Other symptoms like marked fatigability, weakness, peripheral cyanosis, cachexia, orthopnea, PND, pulmonary edema, severe pulmonary hypertension, as we already discussed. All this happens only during the advanced stage of isolated aortic stenosis. Why isolated? We'll discuss it later, because when there is associated mitral regurgitation, mitral stenosis, yeah, aortic regurgitation, sometimes you will have masked symptoms, sometimes you'll have early symptoms. So in an isolated aortic stenosis, you'll have these symptoms late in your course of natural history of the disease. The other important thing we have to know about symptoms column is is when you have some kind of arrhythmia, especially in atrial fibrillation. What is an atrial fibrillation? Your atria is not having enough contractions. When there is no enough contraction of atria, the last 20 to 30% of blood won't be pumped into the left ventricle. Already your left ventricle is not enough compliant to pump blood. Now if your left atrium is also not pumping enough blood because of atrial fibrillation, that will further compromise your cardiac output and then can cause increased symptoms. So when I just discussed about AS plus MS can mask the clinical findings of AS. Sorry, mistake. And we will discuss it when we discuss MS. And then comes AS plus AR, where your symptoms can worsen early and reaches advanced stage in the early decades itself. That is, AS plus AR can worsen, and AS plus MS can mask your clinical findings for initial few years. The physical findings. So the examination part of aortic stenosis reveals: 1. The pulse pressure is narrowed. Pulse pressure narrows over time, and the advanced stages of aortic stenosis will decrease the stroke volume. This decreased stroke volume decreases the SBP as well as pulse pressure. Pulse pressure is nothing but the difference between your SBP and DBP, systolic blood pressure minus diastolic blood pressure. Next comes as pulses powers at TARDIS. This is clearly this significant physical finding, which most of us can't actually do it in our wards, but this is very specific to aortic stenosis. This is nothing but a carotid arterial pulse will rise slowly, and it will peak after a delay, not straight away. It delays and then peaks because the aortic stenosis, which won't let your blood directly enter the carotids or into the systemic circulation due to the stenosis, is called pulses powers at TARDIS. And then thrill and anacrotic shudder is palpable over carotid arteries, and accentuated A wave in JVP is also seen because of decreased distensibility, RV distensibility. You know, JVP wave contains E, C, V, and X and Y descents. Among that, A wave of JVP is increased in advanced stages when the aortic stenosis can increase the back pressures into the left side of the heart, then to the right side of the heart, and then when the right heart is also failing, then you'll see this accentuated A wave in your JVP wave. And then comes apical impulse. Apical impulse is also one of the significant change in aortic stenosis because of the very thick LV left ventricle. Your apical impulse will be heaving. It's a heaving apical impulse. This is not normal. What is heaving apical impulse? Usually you'll get apical impulse visible or palpable only for like 1 or 2 seconds. If it is significantly increased above that 2 seconds of time, 1 or 2 seconds of time, because of the delayed systole against the small orifice of aortic stenosis, the LV systole is delayed. This delay is seen as apical heaving apical impulse in aortic stenosis patients. Double apical impulse. Double apical impulse is seen in aortic stenosis when the patient is having palpable S4. What is an S4? S4 is a hard sound, but when it is palpable, you can feel it as double apical impulse. S4 is nothing but a atrial gallop. Atrial gallop means when your heart, when your atria is pushing blood with a lot of force against the stiff ventricle, then you'll hear a S4. Stiff ventricle is nothing but our concentric LV hypertrophied left ventricle due to aortic stenosis. So S4 is very common in aortic stenosis patients. So then comes systolic thrill. Thrill is nothing but a palpable murmur. We'll come to murmur now. Till then we can see that this systolic thrill can be seen at the base of heart to the right side of the sternum in leaning forward position, or you can also see it in a normal patient at suprasternal notch. You can also feel the thrill. Next, coming to the most important auscultation part. This is very important for your examination as well as for viva or your case presentation sessions. So what's the first and most important thing in your auscultation part is a loss of physiological S2 split. Why is it lost? When your LV hypertrophy happens and your LV systole is being prolonged, you already have a physiological split of S2. It is between A2 and P2. That is atrial heart sound and pulmonary valve heart sound have a little split in between them because of the delayed RV contraction just after the left ventricular contraction. Now, because of the left ventricular systolic delay in aortic stenosis, this physiological split is actually lost in aortic stenosis patients. So you won't have any physiological split. Sometimes in advanced stage, when your left ventricular systole is even more delayed than right ventricular systole, then you might have a paradoxical S2 split where your P2 is earlier than your A2. So this is one of the important thing you have to understand. Next comes this S4 heart sound. S4 heart sound, we just discussed what is S4. It is atrial gallop. Your atria is pumping blood against the stiff left ventricle or right ventricle, whatever it is. Here it is left ventricle. S4 is heard at the apex secondary to LV hypertrophy. That is, and the third one is S3 heart sound. S3 heart sound is not seen in the initial stage. It's very much comes in the advanced stages where S3 heart sound comes after LV is start decompensating and your heart is going into left ventricular dilation. The S3 heart sound is nothing but a ventricular gallop. What is a ventricular gallop? It is nothing but when your left ventricle is very much enlarged. The blood coming from left atrium to the ventricle, this dilated ventricle will produce a sound called S3. So this is usually seen in dilated cardiomyopathy patients, which happens in the advanced stages of aortic stenosis leading to compromised heart failure. So coming to the murmur. Murmur, which kind of murmur? What is the type of murmur heard in aortic stenosis is ejection mid-systolic murmur. It is a low-pitched, rough, rasping kind of characteristic murmur, which is loudest at the base of heart in the right side of the second intercostal space, and it can be transmitted to carotids also. There are two kinds of heart sounds. There are S1 and S2. S1 corresponds to mitral and tricuspid closure, and S2 corresponds to it's S1. Yeah, right. S1 is nothing but mitral and tricuspid valve closure, and S2 is aortic and pulmonary valve closure. So in between these two sounds, you'll get this ejection systolic murmur because this is the time of systole. When this systole happens, your blood is being pumped into the aorta or into the pulmonary veins through this aortic and pulmonary valves, and the sound of ejection systolic murmur happens during this sound. Initially it starts slowly, it peaks in the mid, and then slowly it tapers off by the time it reaches the S2. So that is why it is called as ejection systolic murmur. There is a small thing called Galvadin effect. If you want to remember, you can remember. It is nothing but usually the aortic stenosis murmur usually radiates into the carotids. If at all this murmur is coming back and radiates into the apex, sometimes it can be perceived as a systolic murmur of mitral regurgitation. So that is called as Galvadin effect of aortic stenosis. You have to remember this. And usually the most important usual in aortic stenosis, the grade of murmur usually is 3/6, that is grade 3 murmur, where the thrill is not usually palpable, which where it goes into grade 4 where thrill is palpable. It is just grade 3 and most common. It can later stages it can go into any grade, but a softer murmur happens when in the later stages where your stroke volume is decreased and patient is into the heart failure symptom. Next comes the investigations part. The first investigation which is most available is ECG. In ECG you will get the LV strain pattern. Strain pattern is nothing but it is LV is under strain and it is not getting enough blood. So the ECG shows it as lateral leads or left ventricular area leads as having ST depressions with asymmetric T inversions. These are most commonly seen in 1 and AVL, also in limb leads, but most commonly in V4, V5, V6, which are the lateral precordial leads. Next, and this absence of these LV strain pattern on an ECG doesn't mean that the patient is not having a aortic stenosis. It's just that LV strain pattern can be a pattern seen in aortic stenosis. Next, coming the most important investigation where aortic stenosis is most commonly diagnosed is echocardiography, where aortic wall will be seen as thickened, calcified, and reduced systolic opening of the wall leaflets. And you can see that there is LV concentric hypertrophy in echocardiography. AV size can also be seen, as we already discussed. Severe AS is nothing but less than 1 centimeter square of orifice area. Also, echo helps us to differentiate between valvular AS from other forms of left ventricular outflow obstruction. What can be the other forms of left ventricular outflow obstruction? That supravalvular aortic stenosis, where the problem is with aorta, base of aorta, or it can be also due to hypertrophic obstructive cardiomyopathy that also can look like aortic stenosis. The symptoms also look a bit similar, or there can be some subaortic atrial stenosis where the membrane is the issue. And measuring aortic root and proximal ascending aorta dimensions, especially in BAV patients, because in bicuspid aortic wall patients, when we already discussed, the aortic root is dilated and proximal ascending aorta can have aneurysms. So when these aortic roots and ascending aorta are very much out of proportion, if they are dilated, then you can suspect BAV and further confirm it on echocardiography itself. Then comes the dobutamine stress echo. Why it is needed? Normal echo can not always it can diagnose a aortic stenosis, because in the later or advanced stages of aortic stenosis, when the stroke volume is decreased, your mean pressure gradient between the left ventricle and the aorta doesn't look like it is having more than 40 mm of gradient, because decreased stroke volume. So then you have to go for dobutamine stress echo when you have a doubt. This will confirm you if the patient is having severe AS or not. So this severe AS can also accompany with cardiac output, which shouldn't be missed out. If it is still inconclusive, then you have to go for aortic valve calcium scoring. It is done with CT chest. Aortic valve calcium scoring is usually, the range differs between men and women, because in men there is more of calcification and in women it's more of fibrosis. Also, cardiac MRI can also be used for screening part. You need not use it always. Cardiac MRI can be used for a patient who wants to get screened for all this heart related issues. If he is having any doubt, where he can differentiate between interstitial fibrosis or replacement fibrosis. You need not go into details of this. Then comes the chest x-ray. The chest x-ray, how will you know that their patient might be having a aortic stenosis? Is first thing first, the patient might be having a rounded cardiac apex. This is cardiac rounding apex, where the patient won't be seeing a usual cardiomegaly which is seen in a dilated cardiomyopathy patient is not seen in this patient because of the concentric hypertrophy rather than the dilated cardiomyopathy. Here the patient might also have dilated proximal ascending aorta seen along the upper right heart border. This is called dilated ascending aorta. This will displace this area further to the right side, which we have to suspect about it. Also, sometimes you can see aortic valve calcification, which is more confirmatory on fluoroscopy rather than in just an X-ray, which is most commonly seen on the left or lateral view of chest. You can sometimes see aortic valve calcification. So in advanced stages, X-ray can also see the pulmonary edema kind of bat wing kind of picture, curly lines, where it is suggestive of pulmonary edema in lateral advanced stages, not just specific of aortic stenosis. Next comes a catheterization part. The cardiac catheterization into the walls is not usually recommended because of the chances of embolization. So it is only used in few patients only. The three indications which are mentioned in Harrison are patients who are having multivalvular disease, a patient who is young, asymptomatic, but still having non-calcified congenital aortic stenosis, or the patient is having suspected LV outflow obstruction and which it might not be at the level of aortic valve. Just we have discussed like supravalvular AS or subvalvular AS can be differentiated through this catheterization, cardiac catheterization. CEG is sometimes used to screen patients for CAD. When the patient is having mild or moderate aortic stenosis, when it is not obstructive, as we already discussed in the introduction part, where we said that aortic sclerosis above 65 years can itself cause myocardial infarction. So screening of CAD is recommended in such patients. Coming to the treatment part, medical treatment, which is from the general medicine, most important for general medicine people, is there is no specific medical management apart from the caution that has to be taken. As first thing, have to avoid strenuous physical activity and competitive sports for sure. Even if your patient is asymptomatic aortic stenosis patient, you still have to avoid strenuous physical activity in even asymptomatic AS patients, especially severe AS. Avoid dehydration and hypovolemia because your cardiac output can be decreased due to the concentric LV hypertrophy and stiffness and decreased LV cavity. So having a dehydration can further deteriorate your patient. Patient with severe AS and normal EF plus low mean gradient, which I have discussed, these patients are most oftenly hypertensive. The patients who are having low flow, low gradient, severe AS. So these patients have to be treated for hypertension. These antihypertensions like beta blockers, ACE inhibitors are considered safe and can be used comfortably. The final thing is there is no specific drug approved for decreasing or stopping the progression of aortic stenosis, like statins and RAS blockers, renin-angiotensin blockers are not really approved right now. Surgical treatment, if you want to go through it completely, I have mentioned it in the entire PDF, but simple surgical treatment is, if the patient is symptomatic, you should go for aortic valve replacement. No matter what, if the patient is symptomatic, you should go for AVR. If the patient is having no symptoms, then you have to check for ejection fraction. If the patient is having no symptoms but ejection fraction is less than 50%, then you should again go for aortic valve replacement. no matter what. It's a class 1 recommendation also. And when the patient is having no symptoms and ejection fraction is also normal, then you have to check for markers. What are the markers? Vmax, that is jet velocity at the aortic valve. If it is more than 5, usually it is 4 is severe and 5 is very severe. BNP, that is brain natriuretic peptide, if it is more than 3 times the upper limit of normal, or the patient is rapidly progressing in the disease even without any symptoms yet, then also you should go for aortic valve replacement. So this is in detail of aortic valve stenosis. So let's conclude it here. If you want to go further in this, or want to see the entire PDF, I'll post it in the bio. Please go through. Please do subscribe and like for further videos. Thank you.